So good morning. We are here for the educational platform of the EAU UROLUTS, and we are here with Professor Bonkat, who is the chair of the guidelines on urinary infections. Thank you very much for being here.
Pleasure.
And the topic of your guidelines, I think it's one of the most interesting topic in the urological field, because we deal every day with patients with infection, more than with patients with prostate cancer. So you have made an update of the guidelines this year. So can you just summarize for us which are the difference compared with the last year?
Yeah. So thank you very much for this nice introduction. I cannot add more. I think that urinary tract infection or infectious disease in urology is really covering a broad field that makes it so interesting. And a few weeks ago, I received a letter from the European Journal of Urology, and there has been cited that our summary of our guidelines, which was published last year, is among the 10 most downloaded citations from the last year. So this is showing how much or how big the interest in this disease is. And this year we had brought a lot of changes, from small to huge changes. So if I may start, for example, first with the new classification. And I know you are a urologist as well. And so we had started to clarify the question about complicated and uncomplicated UTI. And this question is not so easy to answer. So if I ask colleagues what is the difference, then one say, okay, complicated is defined by severity, others by risk factors, others by a combination. And what we have done now, we have completely abandoned the term complicated and uncomplicated. Interestingly, the term are quite old. 60 years ago, already this definition has been made. And we are now speaking from localized and systemic infections. This meaning that you have, if you have a patient with fever or symptoms of a systemic infection, then you call it a systemic infections. And if you have only cystitis, symptoms of cystitis, and you have a localized infection. This change seems to be quite easy, but as I said, it took decades until this change, and I hope this will lead to more clear recommendation for clinical practice as well as in research. For example, we have so many high published studies about complicated UTI, but if you go a little bit more in deep and you show it, or take a look in the study population, then it's a mix. So this is one change. We're very interesting, and we will have a publication which is already accepted out very soon. So definition is one part. Then we have added some information about the treatment of cystitis. Cystitis is quite a common thing. Every urologist deals with cystitis. And just to say this out of interest, urinary tract infection, as we know, are quite frequent. And we have around 400 million cases about urinary tract infections per year worldwide. And we have already 240,000 people dying because of UTI in combination with antimicrobial resistance. So antimicrobial resistance is very important to consider. And we have the problem that cystitis is so frequent, and because mainly treated with antibiotics, that this added something to the development of antimicrobial resistance. Therefore, we have added now a chapter about the non-antibiotic treatment. And if I can say so, we have different means coming from analgesic drugs like ibuprofen, for example, which can be used. It helps. So we can spare about 60 to 70% of antibiotics, but we have always to inform our patients that then they have risk up to 5% to develop an upper urinary tract infection. Then we had added information about nutraceuticals and phytotherapy, and there are a few options that could be chosen. The evidence behind this is not so strong, but at least in the context of the risk of the development of antimicrobial resistance, I think it's worth to know about these options and discuss these with your patients.
This is really interesting, because when we see patients usually treated by general practitioner already, they come to us after a number of antibiotic therapies, usually with fluoroquinolone. I'm speaking for Italy, where is not indicated to use fluoroquinolone anymore as the primary treatment. So I think it is really important to have also the possibility of talking with the patient and telling them, look, we are not using antibiotics now, and I think I've read the guidelines, the update of your guidelines, and I think it's really clear stated what is better to do in these cases.
I can not more than to highlight again, because you have brought into this topic, is the use of fluoroquinolones. The fluoroquinolones should not be used in the setting of cystitis. And it's not only a suggestion, it's set by law. They are forbidden. We have no indication for this. So if you use a fluoroquinolone for the treatment of cystitis, then you are off-label. And this is very important to know.
This is very important to inform also the patients about it, because sometimes they do self-therapy and they are used to use this kind of antibiotic. So what about the immunoprophylaxis? Because we know one of the problems of our patients, especially female patients, are the recurrence of the cystitis. So what we are doing to preserve patients from recurrences is also important in our clinical practice. You updated the section on immunotherapy, which is a bit changed compared to the last...
Small, but significant changes has been made. So coming to the topic of prophylaxis, we have different means. I always counsel the patient about means that works, that we know that are working. And therefore we have to say the increase of the fluid, for example, fluid intake, or local estrogenization in postmenopausal women, it's working. And then we have a lot of other means. And immunomodulation is some of the other means. And in recent years, we have given immunomodulation a strong recommendation. But this year, we have been gone again through the literature. We have asked the statisticians from the EAU Guideline Office as well. And then we have seen that the studies, unfortunately, that led to this high or strong recommendation are too old. Some of them are missing critical clinical endpoints like severity of the infection, symptoms, or even cultural clear of the infection, so that we have said, okay, we cannot give this strong recommendation anymore. But of course, they are not forbidden, but they just have not a strong recommendation. And if you would like to have a strong recommendation, I always tell the industry as well, please come with placebo-controlled randomized trials, and then we can see.
And another question, which is more on what about your clinical practice? Because when I deal with these patients, I always ask for their bowel function. And we know that in these patients is really important. So you stated in your guidelines that the correct assessment of patients is really important. Estrogen therapy or estrogen status is really important, but also bowel status. What do you do? How do you deal with these patients? How do you manage the patients according to their bowel function?
This is a question I cannot proper answer, I must say, because I have in mind this bowel situation and the bowel function. And of course, the influence of the antibiotic treatment to the human microbiome, etc. But at this time point, I can at least not give you an evidence-based statement how to deal in daily clinical practice with the bowel of the patient.
Okay, but according to estrogen therapy, you always suggest to start with estrogen therapy in postmenopausal...
It is an option. I always would recommend at least that the patient should be seen by the gynecologist, just to see that there's no risk of breast cancer or other stuff that might be really, at risk then, or bring the patient at risk with hormonal treatment, but then it's a good option.
I will thank you very much for this interview, because it's, again, a hot topic in our everyday clinical practice, and I find your guidelines and the update of guidelines really clear for every clinician, even if it's not really involved in the urinary tract infection. So thank you very much.
Thank you very much for being here.
Thank you. Thank you, and see you soon.